Officially welcome, and thank you so much for joining us for this webinar, Better Together, Exercise Physiology and Physical Therapy in Cancer Care. My name is Karen Wonders. I'm the founder and CEO of Maple Tree Cancer Alliance. Maple Tree is an organization I started 15 years ago. We celebrate 15 years this year. And we provide individualized exercise training to patients as they go through cancer treatment from the time of diagnosis onward through survivorship. Um, we work with many hospitals, many fitness centers, many physical therapy groups around the country. So honored to be here today to talk with you all about this topic. In addition to running Maple Tree, I also work as a professor at Wright State University. I'm exercise science professor there and program director over the exercise science program, as well as the exercise oncology certificate program. And I am here with Dr. Mary Fisher, Mary, would you like to introduce yourself?
Sure, I can do that. My name is, as she said, Mary Fisher. I am a physical therapist with over 35 years of experience in PT, probably about 20 years in oncology PT. I am a professor, department chair, and program director for the Doctor of Physical Therapy program at the University of Dayton. My research is in oncology, rehabilitation, functional impairments facing individuals with cancer. I am so excited to be working with Karen on this webinar and on a research project. I have known Karen for many years, and we finally got the stars to align to work together. So this is a great honor. Thank you.
Yeah, no, thanks for being here. And so just to kind of lay the groundwork for the discussion today, I have a couple of PowerPoint slides that I want to just go through. Again, this is more so just introductory, just to kind of set the stage for why now, why have this conversation now. So I'm going to pull up the PowerPoints. We'll go through a couple of them, and then Mary and I are going to continue the conversation. I'll kind of come back to the main screen where everyone is, and we'll go back and forth sharing screens as things come up. But initially, I thought it would just be important, number one, to really lay this groundwork for what is the workforce when we're talking about exercise oncology and taking care of patients as they're going through cancer treatment. Because as you see, we've got a physical therapist on here. It's not just an exercise professional. And so I think this graphic right here really demonstrates this workforce and what we're trying to do when we're creating a cancer care continuum. And basically, what we have is a hierarchy here. So we have the specialist at the top, that would be the physical therapist, the occupational therapist, those who work with the skills service line and who are, impairment driven. So when things come up with patients that are outside of my skill set as an exercise professional, that is who I would refer patients to. So we see them in terms of a hierarchy, they're at the top. And then this middle layer here, we have exercise oncology instructors. That is what I call my trainers who work on site in the clinical setting. And so, exercise oncology instructor, we'll talk more about that as we kind of go through today, but it's a certification that I have through Maple Tree Cancer Alliance that will certify someone, credential them to work with cancer patients as they're going through active cancer treatment. And it'll teach them how to develop safe and effective exercise programming.
One of the things I really like about this particular slide showing the specialist, the oncology instructor, and the community exercise oncology trainer is there is a role for each one of us.
Mhm.
And perhaps it's just that the specialist has the smallest part of the pie, and or the pyramid, as it were.
Yeah.
That we are just there at the point of impairment, as you mentioned, but it is really, really important for the exercise oncology instructor and community exercise trainer to be there for the longer term.
Yeah, I think that's a very good point. And then as things come up with us, we refer to you and, back and forth. But I think that's a really good point. And then that final piece, the largest one, is really for survivors, cancer survivors, people who have completed active cancer treatment and are no longer exercising in a clinical setting. We do, we work with Livestrong. Mapletree has a partnership with Livestrong where we help partner, we help certify people who work in fitness centers who may or may not have a degree in exercise science or a related field. And so that is a different certification and it credentials people to work with a patient from the time they complete active treatment onward. So you can see as you move up the pyramid, you move up in credentialing, you move up in education, and then as you come down, there is probably a wider net to be cast. I mean, there's 20 million cancer survivors here in the US, but a very limited number of community-based exercise professionals who have certifications in oncology, which is why we're having this conversation.
Absolutely.
Another reason why now is the time is because I have, Mary's been in this field for 35 years. I've been in this field for 23 years now. And never have I seen such momentum in this field. I mean, the whole reason I started my organization was when my grandfather had cancer in 2007. The doctor had no idea that exercise could help him. And, now we are on the brink of this becoming part of standard of care. We're going to talk about that a little bit today. But there's 69 national organizations that have guidelines now recommending exercise for cancer patients. So you're seeing a huge turn in professional organizations, national and internationally. A lot of that has been driven by the research in this field. So if you were to go on to PubMed database and just do a search term exercise and cancer, you would find more than 33,000 published randomized, no, published, peer-reviewed, high-quality journal articles. Of those, there's more than 3,000 randomized control trials, which randomized control trials are the highest tier of research. And that is, if this were a pill, I mean, we think GLP-1s are hot. This would be every single person in America would be signing up for this pill. That is how strong the evidence is. But this research, and one thing that I think is kind of cool because I'm a nerd and I like stats like this. But since 2014, there has been an average of 1,000 papers published per year on this topic. And that is really what has helped propel this to the national spotlight, to the international spotlight. We have people here from other countries that are joining us today because we're seeing this around the world that people are realizing the benefits that exercise can have in a cancer population. And people are starting to do something about it.
Right. And the nice thing about when we see this growth in the research, and I've watched it exponentially take off as well, is they're really starting to understand the role of exercise even at the impairment level. So not just at the let's get you back into your active lifestyle, let's get your fitness back up. We are seeing the role that exercise can play in mitigating cancer side effects.
Mhm.
I'm doing a lot of research right now on cancer-related fatigue, and the number one recommendation, we know that exercise helps
Mhm.
deal with cancer-related fatigue. So this growth in research is phenomenal because it's targeting the real problems that people with cancer have.
Yeah, I mean, fatigue I think, is a great example because it's probably the very last thing that people want to do when they're experiencing that fatigue. But
True.
you're right, it helps them more. I mean, it helps them more than anything else that they can do. So I remember when my grandfather had cancer and it was exhausting for him even to be fed food. And, the idea of exercise seemed really intimidating, but just meeting them where they are, doing what they were able to do for him, it was just a lap around the downstairs of his house. I mean, that really boosted his energy levels. And, I believe it's what kept him in his home until he passed away. So, yeah, I think it's very valuable. And I think that's also what makes it matter to patients. We care about so many things, but if they're so fatigued that they can't eat, they want that fixed. And so if we can
Absolutely.
speak into that and say, okay, here's what's going to help you, there's evidence, it's going to, it
And
give
immediate
it a shot.
tangible benefits,
Yes,
right?
exactly.
Immediate tangible
Yes.
benefits.
And
Yeah.
we all like instant results here, don't we?
Yeah.
I thought that this might be interesting to share with all of you as well. So Maple Tree, you know me from Maple Tree, and I'm, a proud, proud spokesperson for Maple Tree. But there are more than 2,300 other exercise oncology programs in the US right now. So we are not alone in this. There are more and more programs popping up every single year, particularly as this gains momentum, as people are talking about it. A lot of health systems are looking to put in an exercise oncology program, figure out how they can work with their physical therapy team to implement some of these programs. And so the what we're sharing with you today goes beyond Maple Tree. It goes beyond UD and the physical therapy school. I mean, these are implications, this hopefully will help you work in this field wherever it is that you live. Of course, if you want to work with Maple Tree, give me a call because we can figure something out. But I do want you to know that this is something that has grown much bigger than Maple Tree, much bigger than, either Dr. Fisher or myself. And then, one of the things that I always talk about whenever I'm explaining to someone who's brand new to the field of exercise oncology is they kind of want to know, well, what does that look like for a patient when they're in active treatment, when they're done with active treatment, when they've just been diagnosed? And so I think this flow diagram here can be really helpful to explain that. And so at Maple Tree, and it could be different with other programs, but at Maple Tree, we will take anyone at any part, any time during the cancer care continuum. So from the time of diagnosis onward. In our clinical settings, those individuals are in active treatment. But when you think of active cancer treatment, is that surgery? Is that chemotherapy? Is that radiation? Like there's so many different things that can constitute active treatment. And so everything we do is individualized to that person. So it's one-on-one exercise that we do. But this is kind of the basic structure that we follow. So we have a phase zero, which is prehab. That's the time of diagnosis until surgery. Sometimes we get a couple of visits with them. Mary, this is oftentimes something that we work with physical therapists on. Do you want to touch a little bit on like what prehab might look like for a PT?
Sure, sure. So I love the opportunity to have someone like Karen and Maple Tree around for the prehab phase when what we're trying to do is improve fitness so that they can tolerate treatment, right? So that's one really important reason to have prehab, especially in, say, a lung cancer population. But the other part of prehab can be understanding what treatments are coming down the pike and trying to mitigate any problems they might encounter from an impairment perspective. When I
Mm-hmm.
think of that, I think of, say, breast cancer. They often need to undergo radiation. If they don't have adequate range of motion in their arms, the prehab for me is going to work on that sort of thing.
Mm-hmm.
If they have postural dysfunction, and we know how aggressive or how much people respond to mastectomies and radiation, where their posture may change. If they already have predisposed postural dysfunction, I'm going to address those problems as early as I can, again, to mitigate the long-term problems that happen with the treatment. So again, it's a partnership, right?
Mm-hmm.
We want to get
Yeah.
them, we want to get them away from that level of frailty and into a better fitness, but we
Mm-hmm.
also want to address their impairments.
Yes, exactly. And actually, I was just talking to a brand new hospital system this evening, and the idea of prehab came up, and they have a pretty robust onco PT program within their network. And my recommendation to them was start sending patients to prehab. They did not have a current prehab program. They were like, "Oh, well, I've heard of this, but it was not something that they were doing yet."
Sure,
And so
sure.
I think that is the best way at the time of diagnosis to get them assessed, to get them evaluated, to kind of see what their baseline is, and then we can set the plan for how we're going to support you as you go through cancer treatment. I think that that's so important in helping just get that patient off on the right foot.
Sure. And
Understanding.
if anybody's familiar with the prospective surveillance model, which was introduced in breast cancer out of NIH work, we should have touch points with these patients all along the way so that, again, we can intervene early. We can figure out what the problems are from the get-go and not have them grow.
Yes, right, right, which is huge. I mean, it's so great for the patient. It probably saves a lot of money for the health systems and insurance payers. And, anything that saves them money, they want to hear more of.
Absolutely.
So
And there's actually evidence to show that. So
yes,
yeah.
yes, I have published some evidence to show that. So that's prehab. So time of diagnosis, preparing them for surgery. Phase one at Maple Tree, we categorize someone in phase one as someone who's in radiation or in chemotherapy. This can be done either by a PT or by an exercise professional. This is really going to be largely driven by the individual and if they have any impairments or not. For our exercise program, when we're doing exercises with them, our main goal, if they're in a phase one, is we want to protect their immune system. And so generally we will keep them at a lower exercise intensity while they're going through treatment like this. And ideally, that helps to preserve their immune function. And what it can do is it can limit or reduce the number of dose delays and dose reductions that happen in chemotherapy. So if you're unfamiliar with the cancer treatment and how that works, when someone goes into chemotherapy, they'll take the blood, they'll look at their white blood cell count, they'll look to see if their immune system is strong enough to handle that chemotherapy that they're going to get. And if they see that their immune system is weakened, sometimes what they'll do is they'll say, okay, instead of giving you this full dose, we're going to give you, 75% or 85% of the dose. We'll give you less of the medicine. Or what they might say is come back in a week and we'll test it again and then we'll give you the chemotherapy then. So dose delay or dose reduction. Anytime that happens, that is not a great thing for someone going through treatment. You want to get all of your medicine and you want to get all of your medicine on time. And so the more we can protect someone's immune function, the more likely they are to get through their chemotherapy with minimal dose delays and dose reductions. We actually published a study in Maple Tree a couple years ago looking specifically at dose delays and dose reductions in people with advanced cancers. We looked at 27 different tumor types, about 100 million different chemotherapy regimens. And we found that the patients that exercised during chemotherapy treatment had significantly fewer dose delays and dose reductions than the people who were not exercising. So that was huge just to be able to show the value of exercise when someone's in treatment. A lot of times people will say, oh, I want to wait till I'm done with my chemo. Oh, it's too much. I'm going to wait. But if they continue to exercise, and this study was even with advanced cancers, so stage three, stage four, we found that no, exercising actually does help you to get more of your medicine to stay on your treatment course. So it's really important. Phase two, generally that's going to be someone who's either completed chemotherapy and radiation, or maybe they didn't need it. Maybe they've got hormone therapy or another type of targeted therapy. This is still considered active treatment. It still takes place in the clinical setting. Usually, this is an exercise professional that does this unless an impairment arises. And our main goal here is self-efficacy and empowerment. We want to teach people how to exercise on their own so that they continue exercising once they hit phase three, which is survivorship. That's what's going to take place in the community with one of our community trained partners. So that is the basic cancer journey and where exercise and PT can kind of fit into that. But all that being said, I think it's important to discuss how do you know, Mary, how do you know if someone needs PT or if they need exercise? What does that look like?
Well, for me, what it looks like is when I'm doing an assessment, patients refer to me, do they have an impairment? Is there a functional deficit that is specifically remedied through physical therapy? Is it a balance deficit that I need to work on? If they have a chemotherapy-induced peripheral neuropathy, do I need to address, risk of falls, that sort of thing? Is it an arm function in breast cancer? Is it muscle wasting that you might see with ADT treatment in prostate cancer? Is it lymphedema, which could be either a breast cancer situation or even a urogenital cancer situation where they're doing those node dissections that end up with problems. Those are all very specific, specialized care pieces that say, you need a PT, or you
Mhm.
need an OT, or you need a specialized, highly specialized uh, focused care. Are
Mhm.
you just feeling like it's hard to get through the day? Are you feeling weak, but you don't have any specific, it's generalized weakness? Are you feeling like you can't get through the work day because the load is too much, whatever that looks like, your stamina, your endurance? That's when I feel like, okay, this is less specific.
Mhm.
And that's when we refer out. The other part of it, I think, is the complexity, right? Are there medical complications that require a specialized professional to manage? What's the medical workup like? Do we have issues that the physician needs to be closely aligned to address as we move through this? Anything that has high risk, high complexity probably stays in that top of that pyramid. As we get into the moderate or lower complexity, we're moving down into that pyramid.
Mhm. Yeah, that's very helpful, I think, especially for the exercise professionals that are here and listening and wondering where does my lane end and where does a physical therapy lane begin? Because I always say it's so important that we stay in our lane. And, for the credibility of our field, we need to understand when something is beyond our scope of practice, when do we refer out and what does that look like? One of the tools that I wanted to share with you all is this. This is the Exceeds questionnaire. This is what we utilize at Maple Tree to triage our patients. And so at most of our sites, we have sites all over the country. And some of them, they have in-house PTs that we can work directly with. Others do not. And so we have to work within the community to make referrals that way. And every patient that comes to us, we have complete this Exceeds questionnaire. This was developed by Kelly Covington Wood, who is a researcher in this space. And for me, I love this so much because this helps keep us in our lanes. So essentially, this is something that the patients can complete. And you can see here there's a red box, there's a orange box, and there's a yellow box. If someone answers yes in the red box, that's an automatic referral to physical therapy. I would say at Maple Tree, about 39% of the time, we are referring patients to PT because they've circled yes in one of those boxes. Then we have that orange box down below that approves them for supervised individualized exercise training, which is what they would come and get with us. And then that bottom line, that bottom yellow box is for community-based exercise programming. So anyone who's completed active treatment and who feels like they have the self-efficacy to exercise on their own would be a candidate for that. And so this is a way that we use on every single patient that we see just to make sure that we're staying within the boundaries of the things that we're supposed to be doing. And that seems to help. And Mary, you and I didn't really discuss this ahead of time, so I'm sorry for
That's okay.
that. But one of the things that, I don't feel like I come across it so much anymore, but initially I felt like there might have been a little bit of turf wars between the two disciplines. And I don't know if turf wars is the right way to say it, but,
Yeah,
you
I
know,
could see that perception, but you know, there is a role for all of us. This world is big enough for both of us,
the
and
industry
I
is big
think
enough for
you're
everyone.
right. I think your triage model is part of that.
Mhm.
To answer the question that came up in the chat, Kelly Covington Wood is part of this, but it's bigger than that. And if so, this was written by Nicole Stout and a slew of other authors, and this actually was cited in the Exceeds tool manuscript that um, Karen is referencing here. And this is the other end of it. So the Exceeds tool is great when you're asking a patient, right, about any of the concerns that farm them over to a rehab specialist versus exercise specialist. But this is the other way, right? So if I am looking at whether I need to see a patient or should they be referred to Karen and her group, this is another way. Does the people, do the individuals meet their physical activity guidelines? Um, and if the answer is no, do they want to? And Karen has said most people want to exercise, they just don't know about it. And it takes you through the severity and level of the symptoms and whether or not you need to refer to a rehab specialist or whether you can get them into an exercise program. This to me is part of our teamwork. I
Mhm.
don't need to see every patient. There are times that an exercise specialist is the right person to see the patient. So I don't think we should turf war because we know that our patients would benefit best from our
Mhm.
skill sets.
Mhm. Yeah, I agree wholeheartedly with that. And understanding the scope of practice and the lanes that we're in and where one lane ends and the other one begins, I think really does help build trust with each discipline to understand that, hey, we're in this together. Cancer is bigger than us and our disciplines. And so if we truly are going to impact the 20 million people that are living today as cancer survivors in the US alone, and I know there's people from other countries on here, this is how we, are going to go about doing that, working together. So Mary, I think we've talked about it enough, but just for people who are not completely clear, what does impairment driven care really look like in practice?
So, the goal of a PT is to help people return to function, right? So what we do when we come in and somebody has been referred to us is we're going to do our physical exam and we're going to find out where there are what I call objective findings. Oh, you're not quite as strong as you should be. Oh, your motion isn't quite as good as it should be. We'll do a lot of functional testing that can be subjective testing where the participants answer questions about what they can and cannot do. It could be physical testing of their tolerance to activities. When we find that impairment that prevents them from engaging in some sort of activity, and we're talking more about an activity limitation as well as a participation restriction, that they can't participate in their daily activities the way they need to. That's my impairment driven care. And we're going to address that specific issue to get them back to whatever goal the patient has. Patient-centered care, person-centered care. Doesn't matter what I want to do. It really matters what they want to accomplish. Sometimes it's really obvious. If they come to me with lymphedema, it's really obvious. I need to help them. I need to reduce the limb size. I need to teach them how to manage that independently. I need to teach them how to use compression. I need to teach them when they need to come back to a PT. I need to teach them what the precautions are. That's pretty clear. Sometimes it's less clear, and we really got to dig and say, what is it you can't do that you really want to be able to do?
Yes, yes, because sometimes they don't know how to articulate that.
Right, right.
Yeah.
And we walk them through that.
So you mentioned balance, you mentioned lymphedema. What are some other impairments that you would commonly see?
I see balance deficits, I see fatigue issues, I see lymphedema issues. Um, in my world, that's probably the primary area. I will just tell you there's a little bit of a limitation in the Dayton region. There's a perception that physical therapists just treat lymphedema,
Mhm.
and we
I
don't get
think
the
that goes beyond Dayton. I think that is a common that's why we're doing this, is to talk about all of the other ways that a physical therapist can help someone who's battling cancer.
Sure, it's pain,
Mhm.
right? It's the inability to participate in daily activities because they don't have the stamina, the endurance. It's deficits in, if you are familiar with 6 minute walk tests, it's it's it depends on the cancer. Head and neck cancer can be not in my world, but swallowing. So you're talking the other part of rehab, the speech language pathology. It can be occupational tasks where they can't prepare their meals. They can't do the horseback riding they want to do. And so you have occupational therapy involved with problem solving. And how are there other ways they can accomplish the same thing, but in a different manner? It's the team that makes
Yeah.
it happen.
Yeah, definitely, definitely. So, how would a patient get with a physical therapist? What does that look like?
Yeah, so pretty much we just get referrals from physicians, but I will tell you that US states, I think actually we're up to all 50, are what we call direct access states. So if a person has a problem, they can go see a physical therapist without a physician referral.
Mhm.
There are some hoops we sometimes have to jump through about notifying the doctor and or notifying the insurance company, but you can see a physical therapist without a referral.
Okay. Well, that,
The key for me is getting the word out to
mm,
patients.
yeah, right, right. Yes. Okay, that is super helpful.
On the flip side, how do they get to you?
Well, what a great question. So typically, the way that Maple Tree works in clinical settings is we become a part of the care team, which is kind of unique for an exercise professional. I mean, previously, we did not have a seat at the table largely when it came to oncology care, talking to doctors, talking to nurses, being a part of that team. So that is relatively new. And I would say, it's been a very good thing, I think, for our field, for the field of exercise in general, because I think it's adding a layer of credibility to the work that we do, and it's just showing how important it truly is in the lives of the patients that we're helping. And so, for the most part, we'll get referrals from the physicians, from the nurses, from the social workers, from physical therapists. Really, anyone on that integrative care team can refer patients to us. Sometimes we'll get patients just come to us. It'll be someone, heard about Maple Tree, they heard me speak, they saw, their neighbor or something, and then their grandma gets cancer, and they'll come to us that way. And then if that happens, then what we do is we'll get clearance from the physician to so that we know that, of course, the limitations and contraindications for that person. So a variety of ways they can come to us. I will never turn someone away. So I'm always trying to get people because as you
Likewise.
said, yeah, we want
Likewise.
we want those referrals. We want people to come and exercise. So
So what does that program look like? Week to week, what are you doing?
yes, that is a good question. I get asked this question a lot. And so the typical program that we have, as I said, it's all individualized to that person. So the first thing we do is we assess them. We look at cardiovascular fitness, muscular strength, muscular endurance, flexibility, body comp, balance, posture, all of that. And with that assessment, we can see their strengths and their weaknesses. And then we create the exercise program to address those. And then we also try to include their goals. So sometimes the patient won't come to us and say, well, I know that I have, limited range of motion in my shoulder here. They'll say something like, oh, I can't, it hurts to raise my arm up to get a glass out of the cupboard, or
Exactly,
I
exactly.
I once had a woman crying because she couldn't wash her hair before her appointment, and she knew she was going to start chemo. She knew her hair was going to fall out, and it was just this whole emotional thing. But she had such limited range of motion that she couldn't do that. And so you try to listen to their cues, then you build that into the exercise program. The exercise program is a full body workout. So we do resistance training, we'll do cardiovascular training, flexibility, balance, if that's something that we need to be working on, trying to hit all those major muscle groups. So we'll work with the patient once a week. Now we know guidelines, they're supposed to be 150 minutes of activity a week. We're going to see them for, one day, so we try to give them tools. We have on-demand videos that we make available to them so they can use that, to continue exercising in the off days and throughout the rest of the week. So we really try to meet them where they are and
So
give
so I
them.
kind of have two questions. One is directly related to that number of minutes per week. Um, the newer ACSM guidelines actually kind of modified that a little bit for different types of problems. Can you speak to that a little bit? Like I think I remember cancer-related fatigue is actually less than 150 minutes a week.
Yeah, I think what they did was they kind of made the window a little bit wider. And so I think it's like 3 to 5 days per week, trying to get up to that 50-minute mark or 150 minutes per week. I think they also look at the intensity of the exercise. So if you're doing intense exercise, you can back that down to like 75 minutes per week. But Yeah, I think it is important to take into consideration that fatigue. And you can, if you are experiencing that fatigue, what I always tell people is that something is better than nothing. And so with my grandfather, it was one lap around the downstairs of his house, and then he would go to bed. But what you can do sometimes is break that up into little bouts throughout the day. And so if we're shooting for 30 minutes a day, but 30 minutes in one sitting is just way too much, you can do a 10-minute bout in the morning, a 10-minute bout in the afternoon. People with dogs seem to get this in because they can take their dogs for a walk. Or I'll tell my patients that if they have friends that want to do something for them, but they don't know what to tell them to do, like they don't want to eat another casserole, tell them to walk with you. Come pick me up at 7. We'll go
Yes.
for a walk, even if
Yes.
it's 10 minutes, that's something.
I really like that point of dosing over time because sometimes these are insurmountable aspirations for people. And if you break it down that way, I think they're more likely to adopt a new lifestyle
Yeah.
change, right?
Yeah, if it's doable for them, then they're more likely to stay with it long term.
Right.
If it's something that's going to feel so hard and like such a pain to do, they're not going to, if they have busy schedules, if they have so many doctor's appointments already, those are all going to play a factor in
Sure.
their decisions. So,
So when they're exercising with you, how do you screen for safety? I
oh,
mean,
yeah. Yeah, so what we do is any patient that comes in, we get their medical history and cancer history, and of course, physician clearance. And we also use that triage tool to really look for any kind of impairments that might be present. What is the medical complexity for that patient? What is their exercise self-efficacy is something that we really look at. And so I would say about 80% of the patients we work with at Mapletree have never exercised before. And it's a tall order when someone's never exercised before and they're right in the middle of treatment to really get them to understand the value that exercise can provide for them. And so we are looking at that. Like what is their self-efficacy? What is their comfort level with exercise? I once had a patient tell me she was more afraid to come to Mapletree than she was to get her chemotherapy
oh
because
my
that was her
goodness.
relationship with exercise. It changed my life because I'm one of those people that I love exercise. I've been exercising literally since I was 5, and I just never understood how scary and intimidating it can be for someone who that has not been a part of their life. And she was one of these patients that came to us in a wheelchair. She was getting radiation to her pelvic area and just had the pain from that. And within 12 weeks she was walking independently without a walker. That's how much of a dramatic change that exercise had had on her. So to hear she didn't even want to come, she'd rather get chemotherapy than come to us, was an awakening, I think, for me.
Yes, definitely. Let me quickly look up that article and I'll post the link in here. Do you have a question
Oh,
for me?
looks like he found it. Okay. While you were
Oh,
talking,
good.
I would
Good.
try to find it. I knew Nicole Stout was the lead author on that.
Yeah, the systematic review wasn't quite it, but I'm glad you found it. Perfect.
Mary, can you talk through the stepped care model?
The stepped care model is kind of, to summarize what we've been talking about, right? There's a time and a place for skilled care, specialist care, exercise by exercise specialists, and then community-based care. So this diagram really kind of shows that stepped care model when individuals are at that acute level, that phase one-ish level. And for me, phase one starts before chemotherapy and radiation. I'll see them post-operatively in that interim time, right?
Yes.
So
Mhm.
that's when we're at that skilled care level. We've got to be careful. We've got to watch for infection. We've got to watch their immune system. We've got to make sure that they can actually tolerate the medical treatment that cures the cancer. I'm just ancillary to that, right? So that's that red medical evaluation and clearance for care. Cancer rehab is when they say, yep, you can go ahead. Let's get you moving. Let's get you back on what you need to be doing, depending on what that impairment may be. And then we start to work into that clinically supervised level and then into the community level. You can add to that if you want, Karen.
Yeah, no, I think you summarized it great. It's the idea of lifelong physical activity and really meeting people where they are with what their needs are and then seeing them through all the way so that they can enjoy unsupervised community-based exercise lifelong. I mean, that's what we know. I mean, data would show that that's their greatest chance at not only managing cancer and helping to prevent cancer recurrence, but when you think of all the other comorbidities that come into play, having a lifelong physical fitness is going to be so important in helping mitigate all of those. So I think at the end of the day, it just shows that it takes a team of individuals to really make
Right. We
patients.
cannot do this ourselves.
No, it truly does. It needs a team. We need a team of us doing this together. How can you tell when a patient is ready to transition out of PT into exercise? I
When
told
I'm
you what
not,
we do.
yeah,
How do you guys?
yeah, when I'm not helpful anymore. I mean,
Okay.
frankly put, when I'm not helpful anymore. When they have reached their goals that we set within physical therapy, when I'm just saying like, look, you got this. You know how to manage your lymphedema. We've gotten it, and
Mhm.
you've got your sleeve, and we're good. You can go exercise, and we actually know. I don't. Do you know Sandy Hayes, the
Not
researcher?
personally. I'm familiar with her work. Yeah.
Right. So I believe she's an EP, an exercise physiologist. Yeah, she did some work in Australia or New Zealand. She's got a great accent, and I
Mm,
can't remember which country she's from, but she had done this research about exercise and lymphedema because everybody was afraid to exercise when you have lymphedema. And the thing that came out of the PAL trial with Katie Schmitz was exercise is safe, but wear a sleeve.
mm.
Sandy said that it was stinking hot down there, and she would just let people exercise without their sleeves. They'd sign like a, yeah, I know I should be wearing it, but I'm not going to. And she got them to exercise, and it did not increase their lymphedema. So
Wow.
exercise is so beneficial, right? So when I can't help them any further, I've taken them as far as they can go. They should be done. They should go see you. They should, yeah.
Yeah. No, I think that's really helpful to know. Like there is a point where it's not cut off, isn't the right word, but a transition takes place. Just to give you guys some real world examples from Mapletree, I was able to pull some of the data that we have on our patients. And again, we do the Exceeds questionnaire on every patient that we have. So, a couple thousand patients a year at least. And so of those patients, about 39% of them we triage to rehab. So they go to physical therapy. About 43% stay in exercise oncology. And then there's about 14% there that do both PT and exercise in parallel with each other, which is kind of unique. I don't know that a lot of patients or maybe even exercise professionals on here know that someone can do exercise and physical therapy in parallel.
Right. Because I'm doing a targeted,
Mm.
impairment driven, specific situation.
Yes.
And I see them half an hour to an hour. I'm not going to be able to do it all. So yes, absolutely should be able to
Right.
see both.
Yeah. So you're going to be more targeted. We're going to be a little bit more whole body, universal. But I think it's important we know what you're doing so that we don't duplicate or impair anything that you're trying to do. So,
Right.
that communication really needs to be open and, we need to understand basically this patient and what we're doing with each patient, in
Sure.
order to.
And I think Aaron had a question about how do you express the value of ongoing engagement with community-based programs, even when they require an out-of-pocket payment commitment. I'm gonna throw that at you, Karen.
Let me read it again real close. So I know so this is referring to a couple of the trials that have just been done. So the challenge trial, if for people who are not familiar with it, that was published in June last year, received a standing ovation at ASCO. Basically, it was a very, very well done study looking at colorectal cancer patients, home-based exercise programs, found, I believe, a 38% reduction in mortality for patients who exercised versus non-exercise. And, you referred to a couple other studies here. Without a pocket, just to address that first, exercise right now in the States is not covered by insurance. And so basically the way that the exercise programs are set up is either it's going to be self-pay, the patient will pay for those, or the way that Mapletree works in our hospitals is we raise the money with the hospital and then we use that to provide the services for free for the patients. Now, that's very nice because it's free for the patients, but that does limit us in the number of patients we can see and the number of times we can see them. And so, you're referencing here 3 years, 9 months. Ideally, we would see them forever. I mean, I would love to get a patient in and stay with them and work with them for the rest of their life. But because we have those limitations, really what we try to do in that 12 weeks that we have them is lay that groundwork for educating them, for empowering them, for equipping them to continue exercising long term for the rest of their life. That's what we're ultimately trying to do. And with Mapletree, we do have partnerships in the community that I'll go in, I'll train, I'll certify their staff. I'll give them the materials they need to run a program, and then we'll refer patients directly from our clinical site into those community-based programs so that they can pick up the baton and continue working with them. So that's one option. We also have Mapletree on Demand, which is kind of like Beachbody, but for cancer patients, where it's all tumor specific exercises, all side effect specific. It's tailored to someone who has very low intensity, seated exercises, no exercise equipment. We do have some higher intensities there for the people who can do it. But that is great because that kind of gives them a menu of options where if they don't want to go to a gym, then they have this Mapletree on Demand. They have other resources they can use. If they want to go to a gym, then, ideally we would have those set up in the community to create that continuum of care because that's what we're aiming for is lifelong physical fitness. Um,
Absolutely.
yeah. Do you want to add anything to that, Mary?
No, I just, I can go on a whole soapbox about the healthcare payment system, but this is neither the time nor the place for that.
Oh, I'm sure. And to the exercise professionals on this call, I've been advocating for insurance reimbursement for the work that we do since 2018. And I am telling you, I feel it with everything in me. It is coming. This is going to be standard of care very, very soon. I am talking to three payers right now that are on the path. One has already approved it. The other one has semi-approved it. We're working things out. The other one approached me, asked me for a pilot proposal. So I believe by the end of this decade, we will have a funding mechanism in place. And I believe this is going to be standard of care, which means we need to build a workforce. We need people in this field, physical therapists, exercise professionals working together because the demand is about to be more than any one of us can handle, like more than anything we can imagine is truly what I think. So, Mary, to those lines, can you talk about like physical therapists, how they can get credentialed or certified
Sure.
in this?
Yeah, so I will let you know that I'm getting older. The gray hair's a big giveaway, although I did have gray hair when I was really young. Um, so I have a master's degree, not a doctoral degree in physical therapy. I have a PhD. I also have been a practicing therapist for so long. The oncology specialty board certification came on way late, and because I'm an academic, I don't have enough clinical hours to actually be certified. Um, but in the PT world, there's board certification in oncology rehabilitation physical therapy that can be done by working, 5 years in the field and sitting for an exam, or you can do a residency in oncology PT, and then sit for the exam. So you can get a board certification as an oncology physical therapist. You can also become a certified lymphedema therapist. That is actually a little broader than just a PT. That's anybody, honestly, in the medical field. And I wonder if EPs could do it. I'm not sure you'd be interested, but um, they have to have college level anatomy and physiology, but it's open to PTs, OTs, physicians, massage therapists, honestly. Um, and so you become certified. That's 140 hours, 130, 140-hour training program. I did it in Europe. I did it in Germany. It was over a course of 3 weeks. So you can become a certified lymphedema therapist as well.
Very good. Thank you. And I will say we have had physical therapists go through our certification as well. We partner with the IPT, International Physical Therapy Association, and have had many go through ours. I can touch a little bit on the certifications for exercise professionals. There are many. I know a lot of people on here know ACSM, American College of Sports Medicine, has a certificate in exercise oncology that they provide to their certified members. There is the Cancer Exercise Trainer Institute, which is offered by Andrea Leonard through ACE. And then my personal favorite, just kidding, is the Exercise Oncology Instructor Certification. That is what we offer through Maple Tree Cancer Alliance. And basically, the way that our program is set up is it credentials someone to work with a patient from the time of diagnosis onward. So we cover the basics of cancer. I think it's important to have an understanding of cancer biology, how the different cancer treatments work, and then what side effects arise from those treatments. Because really, with exercise, what we're doing is we're trying to target those side effects and help them to improve the symptoms of those side effects as they're going through the treatment so they can tolerate their treatment better. So, uh,
Karen, I have a little story for you. Way back in the day when I was a little tiny PhD student in, I think it was 2007 or something like that, I did a systematic review on exercise after breast cancer, because at that point the PAL trial had not been, maybe it
right.
was in 2009, because the PAL trial had just been published. So it
I
may have
think
been,
that came out like 2008, 2009.
yeah,
So,
so it was right around that time. And I remember finding all this literature and saying, why wouldn't you exercise? It,
hmm
it prevents recurrence and it is the number one thing to make sure you don't die. Why
hmm
wouldn't you exercise?
Yeah, well, I agree. That's why I started my organization. Well, I couldn't believe it when, I had a PhD. My all of the research I had done, it was an R1 institution, was on cancer and exercise. So I was totally, I mean, I would stop people in the stores if it looked like they had cancer and ask them if they were exercising. I mean, I was that aggressive about it. And so when my grandfather's diagnosed, he was already very active, but it was a very aggressive tumor. I mean, it was a bad diagnosis from the beginning, and I just couldn't believe it when his doctor at one of the best cancer institutes in the country told me I didn't know what I was talking about and that cancer patients needed to rest. And I'm sitting here thinking, I just won a Dean Citation of Excellence for my dissertation on this very topic. I think this
I
is
think I know what you're doing, right?
yeah, it was crazy. But I think it's so encouraging to see where we've come from now. Like that was 2007. And up until 2010, that's what doctors were telling their patients. And then it was, oh, avoid inactivity. Maybe there's something to this exercise thing. To now, we're sitting here saying, hey, a standard is coming. Insurance is coming. I mean, very soon. I keep saying by the end of this decade. I believe it's by the end of this decade. It could take longer. Everything takes longer than what I want it to, but it's coming. And that just is a testament to the work and the researchers that have been publishing and sharing the information and, talking about it, having a
Sure.
conversation about this. So we are coming up on the hour. I want to thank you, Mary, for your time. I want to thank
This
everyone
has been
on
fun.
Yes, it has been very fun. Just as a closer, real quick, anyone that's interested in taking the EOI certification or going to check it out, you can scan this QR code and use that coupon here. You'll get 20% off. So I'd love to, and if you have any questions, please feel free to reach out to me. And then anyone that's interested in following us on social media, particularly Maple Tree Education. We try really hard to speak directly to you guys with with this social media channel. So giving you a behind the scenes look at what it takes to work with this population, what are some common things that we see, how do we work around different symptoms, how do we develop different exercises based on different things. So please give us a follow there. I'd love to grow our platform a little bit more just because I know how important it is to build a workforce. And I believe that is all we have for today. So thank you again for coming, Mary. Thank you so much.
Thanks
And
for having
enjoy
me.
what's
Loved
left.
it.